Addiction is a health condition, not a character flaw. In public health and clinical literature, it's understood as a chronic, relapsing brain disorder that changes how reward, stress, and self-control systems function. Those changes make stopping hard even when someone is deeply motivated to do so. The starting point for health equity is simple. Treat addiction like other chronic conditions because it is one. Thinking equitably means looking upstream at context, not just downstream at behavior. Risk goes up when substances are easy to access, whether at school, in social settings, or at home. How a substance is used can matter too, because some routes can lead to faster reinforcement. Genetics and mental health challenges can increase vulnerability, and family or peer dynamics, like limited supervision or difficulty refusing, can shape when and how use begins. None of this is inevitable. It's a map of where prevention, connection, and support can make the biggest difference. Clear language helps. Substance use disorder, or SUD, is a diagnosis based on patterns, like continued use despite harm. The more criteria someone meets, the more severe the disorder. At the high end, SUD aligns with what people often call addiction. Those criteria fall into 4 buckets: impaired control, physical dependence, social problems, and risky use. Using precise, person-first language reduces stigma and opens the door to care. 2 ideas that often get misunderstood are tolerance and withdrawal. Tolerance is the body adapting so more is needed to feel the same effect or even to feel normal. Withdrawal can include a short, intense phase followed by a longer period of emotional and cognitive symptoms. Both are physiological processes. Recognizing them as such helps us move away from blame and towards steadier, more respectful support. So where does equity come in? Access isn't even. Many rural and low-income urban communities have few options for care. Insurance can be inconsistent or slowed by administrative hurdles. In busy clinics and emergency rooms, stigma can creep into the interaction and make care feel rushed or dismissive. Poverty increases exposure to drug markets while shrinking access to supports, especially in places where services were historically underfunded. These are system-level problems, not individual failings. Public perception matters too. When people are labeled dangerous, unreliable, or weak, shame and fear push them away from care. At the same time, our culture often normalizes alcohol while criminalizing other substances. An equity lens replaces judgment with dignity and punishment-first reflexes with practical problem-solving. So how should we think about action? Think in terms of a recovery-oriented ecosystem. Meet people where they are, lower barriers at each step from screening to follow-up. Build trust with consistent, person-centered care. Use non-stigmatizing, person-first language. Engage peers and people with lived experience. Align campus learning with community realities so students understand both the science and the systems and help reshape both over time. At Voices of Equity, we're committed to raising awareness, sparking conversations, and driving action around health equity. Whether you're a student eager to learn, a professional looking to contribute, or someone who wants to support equitable change, there's a role for you in this journey. So what can you do today? Start by visiting our website, thevoicesof.org. Explore inspiring stories, access valuable resources, and discover opportunities to get involved. Your voice matters. Join the movement and make it heard.